I'm Kate Jordan. I'm the developer of the Bodywork for the Childbearing Year Advanced Certification Training in Pregnancy Massage Techniques for Pregnancy, Labor Support, and Postpartum Bodywork. Today we're going to talk about low back pain in pregnancy and some techniques that you can use to significantly minimize or at times eliminate your client's experience of back pain. Back pain is one of the most common dysfunctions that pregnant women experience. 60% of pregnant women have back pain at some point in their pregnancies, and 33% of pregnant women have severe back pain. And that back pain can be felt in the upper back, but it's more commonly felt in the lower back, in the lumbar area, and in the pelvic area. We're going to be talking about back pain specifically in the low back area today. Women experience back pain in pregnancy for a number of reasons. If a woman already had dysfunction in her lumbar spine, if she had a disc degeneration in her lower back, if she'd had sciatica previously, she's more likely to get back pain in pregnancy. If she's gained a tremendous amount of weight, she's more likely to get back pain in pregnancy. If she has a job where she does a lot of sitting, 8 to 10 hours a day, or does a job where she has a lot of standing, 8 to 10 hours a day, she's more likely to get back pain in pregnancy. And she's also more likely to get back pain if she's experiencing severe stress. And why would previous dysfunction or new kinds of stressors during pregnancy contribute so much to back pain in pregnancy? Because as the uterus grows through pregnancy, the change in the orientation or relationship of the lumbar spine, the sacrum, the pelvis, and the hip joints changes dramatically. And the pelvis moves more and more into an anterior rotation, which dramatically increases the lordotic curve of the lumbar spine. Pregnant women also tend to balance the anterior weight load of the enlarging uterus with a contralateral leaning back or extension of the rib cage. And this does nothing more than to increase their experience of back pain. The two muscles that are most commonly involved with the experience of back pain in pregnancy are the quadratus lumborum muscle and the psoas muscle. We're going to address each one of these muscles with a different kind of manual therapy technique. The quadratus lumborum muscle is a muscle that's involved in all of the actions of the torso. So if an individual is flexing, extending, rotating, or side bending, they're going to be using the quadratus lumborum muscle. If you look at this graphic, you have a very clear picture of the many different fibers and directions or angles of force of the quadratus lumborum muscle. This diagram is a graphic representation of the quadratus lumborum muscle on the left-hand side and the directions of the fibers of the quadratus lumborum on the right-hand side. So if you look on the right-hand side of the screen, you'll see fibers that run superior to inferior from the inferior border of the 12th rib down to the crest of the ilium, from the inferior border of the 12th rib down to the transverse processes of each lumbar vertebrae, from the transverse processes of each lumbar vertebrae down to the crest of the ilium, and from the transverse processes of each lumbar vertebrae up to the 12th rib. So these very many lines of force can potentially be involved in dysfunction in the lumbar spine or in the muscle itself. And you can see on the left-hand side, the visualization of the muscle shows the muscle originating at the inferior border of the 12th rib and then traveling to the tips of the transverse processes of the 5 lumbar vertebrae, and then inserting as well on the superior edge of the crest of the ilium. We're going to use an osteopathic technique, strain and counterstrain, to look for and then to extinguish tender points in this muscle. Karen is 31 weeks pregnant, and she is experiencing back pain in her upper lumbar area. She's on a Veneto electric table, and I'm going to raise that table now. We lowered the table to enable her to get on the table very, very easily. And now I'm going to bring it up to a level that's going to enable me to work effectively. And the table height that's most appropriate for pregnancy massage is a table height that's at the level of your wrists. So this is much higher than a table height that you would use if you're working with a client in prone or supine. And you'll see that this table height now is potentially higher than a level that you might use previously. And what this table height enables me to do is allow my body weight to shift directly into her body, rather than hinging my body at the waist and sinking down toward the client's body. I'm just going to allow my body weight to move laterally into her body. And we're going to be looking at specifically the lumbar spine and the origins and insertions of the quadratus lumborum muscle. We've just looked at a graphic of that muscle. I am going to look for 7 tender points on the quadratus lumborum muscle. And these tender points are going to be at the inferior border of the 12th rib, the superior edge of the crest of the ilium, and on the tips of the transverse processes of all 5 lumbar vertebrae. I'm going to use a grease pen to demonstrate for you exactly where these points are. I'm going to follow the inferior edge of the 12th rib up to T12, move laterally an inch. I'm going to palpate a point just inferior to the 12th rib. I'm then going to palpate 5 points on the tips of the transverse processes from L1 to L5. And then I'm going to palpate a point just superior to the crest of the ilium at the level of L5. So that one hurt. And that was my pen. And I'm looking for the most tender point in this area. If I extinguish this tender point, I will have extinguished all the tender points in the quadratus lumborum. So Karen, I'm going to touch 7 places on your back, and what I'd like you to do is tell me if any of these places hurt. Are you ready? Got number 1, number 2, number 3, number 4, number 5, number 6, number 7. So there are so many points, Karen. What is your favorite point?
7.
Yeah. So this point hurts more than any of the other points. But Karen had a lot of places that hurt, which is great for me because I'm going to demonstrate extinguishing a point closer to the rib cage, and then I'm going to demonstrate extinguishing a point closer to the pelvis. So this point right here also hurt, as your wince is telling me. So what I'm going to do to extinguish this point, which I'm no longer pressing, I'm monitoring with a soft fingertip, is I'm going to rotate Karen's rib cage either toward me or away from me. And this is an experiment. I don't know which diagonal fiber is involved here. And Karen, your job is to be completely passive. And I'm going to check this point here, and we're using a scale from 0 to 10. 10 is excruciating, unbearable pain. 0 is the pressure of my hand. What does that feel like there?
3.
Okay, and what did it feel like originally?
8.
8. So we have had an improvement. So I'm going to take you just a little bit further. I'm rotating the rib cage. And how's this now?
1.
Okay, so we're looking for a place where you feel my hand, but it no longer hurts. Are we there? Okay. So Karen, what I'd like you to do now is to let your left cheekbone fall back down to your pillow support. Now Karen is resting in side lying with the side lying support system. She has a very firm bolster under her right leg. She has significant support under her torso with the torso pad, and she has a very unique head pillow that's supporting her head. I'm going to hold her in this position for 90 seconds. Now this technique that I'm using is called strain and counterstrain. Strain and counterstrain was developed by an osteopath by the name of Lawrence Jones, and it relies on my ability here to extinguish aberrant impulses from spindle cells that are wrapped around individual muscle fibers. And spindle cells are stretch receptors or proprioceptors. And this is an indirect technique. So I'm taking this particular muscle, the quadratus lumborum, and not just this muscle, but specific fibers of this muscle, and putting them in a position of ease. Once they're in this position of ease, those stretch receptors are no longer activated. And when I bring Karen back to her original position after 90 seconds, she'll no longer have any pain or discomfort in this area, or a very minor amount of discomfort. A counter-strain application will be considered successful if the pain level decreases by 70%. I like to decrease it by 100%. And what I'm going to ask Karen to do is, she's resting in this position, is to allow her body to relax around this position. And this, Karen, if I'm not mistaken, is the position that you described to me that you end up sleeping in at night, half on your back. And so that tells me that that position, sleeping half on your back, is what contributes to your back pain. One of the unique aspects of counter-strain as a manual therapy is that the position that one finds that is pain-free is the position that caused the pain in the first place. I'm going to take you back to your original position, Karen, and we're going to check this point. And on that scale of 0 to 10, how does this feel?
It doesn't hurt at all.
Do you feel that I'm not in the same place that I was before?
No.
You know, you trust me. Oh, good. So of course we're in the same place, and now she's pain-free. Now if, in extinguishing this point, in rotating Karen's rib cage toward me, her experience of pain increased rather than decreased, I would know that I had moved her in the wrong direction. And the alternative direction for extinguishing this trigger point would be to rotate her rib cage away from me. So using her arm as a lever, I'm dropping her arm off the table in front of her body, which will rotate her rib cage in the opposite direction. So if, after I'd found the tender point and I rotated the rib cage toward me, she experienced more pain, I would change the direction. And now we're going to work on another tender point in the quadratus lumborum, and this was the point that was the most painful for Karen, and that's the point that is just superior to the crest of the ilium. And I'm going to touch this point again. It won't hurt as much because I worked here, but it still hurts, right? Okay. So to extinguish this point, I'm either going to rotate the pelvis toward me or rotate it away from me. I'm going to use Karen's leg as a lever. I have a soft hand just below her knee on the tibial plateau, and you are helping me, Karen. So I want you to be completely passive if you can, and tell me what this feels like.
It doesn't hurt as much.
Okay, so on that scale of 0 to 10, if 0 is the pressure of my hand and 10 is excruciating, what's this?
A 1.
Okay, I'm going to take you into a tiny bit of extension, a little more rotation toward me. How's that?
Yeah, I don't feel anything.
Good. Now I'd like you to relax in this position. Now as Karen relaxes in this position, which is going to diminish or eliminate her experience of pain, I'm going to maintain the effort that I used to place her pelvis in this position. So once I placed her in this position, if I relax the effort that I'm exerting with my right arm, which is placing her hip into rotation toward me, then this point will not extinguish. So I need to maintain that amount of effort that I'm using with my right hand, the working hand. My other hand is monitoring the point. So my fingertip is resting on the skin. I no longer have pressure on this tender point. And this is how counter-strain differs from the trigger point massage as taught originally by Janet Travell and David Simon. There is no deep pressure on the tender point or the trigger point here. Jones' tender points are similar to, but not the same as, Travell tender points. And I'm going to bring you back to your original position. And how's that?
Great.
So we're going to call that great, or we're going to call that good. Do you like great better than good? Now, once I've extinguished these tender points in the quadratus lumborum, I need to flush the area. So whenever counter-strain is applied, immediately afterwards, I'm using a lomi-lomi technique here. The area needs to have Swedish massage flushing motions, what I call milking motions, that are going to increase blood flow into the area, removal of metabolic waste products, increase of oxygenation. And this should just feel pleasurable. The The second muscle that's commonly involved in back pain and pregnancy is the psoas muscle. Under no circumstances should we be directly addressing the psoas muscle. It is possible to touch the psoas muscle in pregnancy, but it's not appropriate. Deep pressure touch on the psoas muscle can initiate uterine contractions later in pregnancy. But the psoas muscle, because it attaches to every lumbar vertebrae, is a common contributor to back pain in pregnancy. And the psoas muscle is often shortened or spastic as pregnancy progresses. I'm going to use another manual therapy technique, an osteopathic technique called muscle energy technique, to address the psoas muscle. Muscle energy technique was developed by another osteopath, Dr. Fred Mitchell, and it relies on moving a joint that is immobile or has limited mobility to what is called the motion barrier, and then using an isometric contraction on the part of the patient or the client with very controlled specific resistance from the therapist, moving the joint and the spastic or strained muscle to a new motion barrier. So increasing motion, decreasing spasticity. I'm going to be working indirectly on the psoas muscle. I will not be touching it directly. So I'm going to place a soft hand on Karen's ASIS, and with my other hand, I'm going to draw Karen's leg back into extension. Now, extension is the opposite of flexion, not hyperextension. And with pregnant clients, what you'll find is that you're not able to usually get into full extension, and that is a result of the shortening of the psoas muscle in pregnancy. So right now, even though we're not in full extension, I'm at Karen's motion barrier. And what the motion barrier feels like is a breaking on the part of her tissue. I'm not at the end of her range of motion. I'm not creating a stretch with the psoas muscle, which can also be very inappropriate in pregnancy. So at this point where I've reached the motion barrier, I'm going to take that hand that was on the ASIS and place the entire forearm and flat hand centrally on the rectus femoris muscle. And what I'm going to ask you to do now, Karen, is I'd like you to bring your knee up towards your chest with not a lot of effort, and I'm going to resist your motion. And I'm going to resist Karen's motion for 5 seconds, and we're going to let everything relax. And then I'm going to take her to a new motion barrier. I want to make sure as I work on the psoas muscle that I haven't abducted or moved her upper leg away from the midline. That's another plane of motion. So I want to maintain a pure extension of her leg. So I've gone to a new motion barrier. Now this time, Karen, when you bring your knee up towards your chest, I want you to work half as much. That's perfect. That amount of effort is perfect. She does not need to use a lot of effort. She's efforting enough that we're going to be able to move her to a new motion barrier. I'm resisting her motion with my forearm. And I'm going to let everything relax. And once again, I'm going to take you to a new motion barrier. And you are very tight here. So this is as far as we've gotten. We've just gotten literally into extension. And this time, as you bring your knee up towards your chest, I'd like you to do a little pelvic tilt and curl your tailbone towards your belly button. And that's it. A little pelvic tilt there, Karen. And you keep working, and I'm going to keep resisting. And let everything relax. And then once again, I'm going to take you to your final point of mobilization. So this is mobilization of the psoas muscle, and this is only done for one set, or one set of 3 repetitions in an individual session. As I look at Karen individually, I can see that this is something that she really needs, and this is definitely involved in her experience of low back pain. And this was the one technique that I thought would be very useful for you. I'm slowly going to bring Karen back to neutral position. I will not be checking the psoas muscle to see if it feels any better. So these 2 approaches, strain and counterstrain for the quadratus lumborum, muscle energy technique for the psoas muscle, using these 2 techniques on your pregnant clients will have a significant effect on their experience of back pain. Thank you, Oakworks, for having me.